Hello, it is a great honor to have this opportunity to talk at the annual spine meeting of Philippine Spine Society. I would like to express my gratitude to the President and all members of the Society. The topic, Surgical Complication in Adult Spine Deformity ASD Surgery, which I was given, is too broad, so I will focus on some surgical complications that I have encountered in ASD lumbosacral fusion. ASD, particularly lumbar scoliosis, is often treated universally with lumbosacral long fusion, as shown in the slide. However, the high rate of acknowledged complications, including both medical and implant-related complications, has become a constant issue when considering lumbosacral fusion. Of many implant-related complications, I will pick up the SI joint degeneration as one such distal adjacent problem of lumbosacral fusion in this talk. I am certain that, as spine surgeons, we all understand that lumbar spine fusion increases the mechanical stresses at the SI joint. Today, I present a case in which I performed a two-staged combined anterior-posterior fusion from T5 to the sacrum because the patient complained of unbearable low back pain with an 86 degrees thoracolumbar scoliosis at 38 years of age. The scoliosis was corrected to 25 degrees, and the patient's subject complaints completely disappeared postoperatively. I followed up with the patient periodically for more than 20 years. Her scoliosis has been preserved as of her last follow-up. Nevertheless, please pay close attention to the sagittal curvature alterations throughout the follow-up period. Her thoracic kyphosis gradually progressed from 29 degrees to 49 degrees. When we look at the patient subject symptoms, she did not have any symptoms for the first 5 to 10 years. However, she complained of right buttock pain without any objective signs when she returned to my clinic at 10 years post-operatively, which led me to suspect SI joint degeneration. When she came to my clinic at 15 years post-operatively, not only did she have right buttock pain, but also she had right lower extremity radiating pain with numbness and dysesthesia on the right calf and sole area. An SI joint lesion was suspected, and I performed an SI joint block. Then the pain disappeared for the next 2 days. At 20 years post-operation, I recognized muscle weakness on the right toes with positive Patrick's and Newton's tests with diminished deep aggress tendon reflexes. This slide shows serial CT images of the SI joint during follow-up. You can see degeneration of right SI joint with a slightly ventral sacral displacement. This case raised two questions. The first, do radicular symptoms caused by lumbar root irritation occur even in patients who have solid union of the lumbosacral segments? Second, if so, what is the mechanism of its occurrence? To answer these questions, I investigated other patients with ASD who underwent lumbosacral fusion in my series. The inclusion criteria are shown in this slide. There were 32 patients who were followed up for longer than 10 years postoperatively. Of them, 5 patients have symptoms related to lower extremity radiculopathy. This slide shows the demographics of 5 patients. Adult idiopathic scoliosis was observed in 4 patients, where the other patient had cerebral palsy GMFCS1. The mean of fusion segments was 10.6 and mean follow-up duration was 13.9 years. All patients were fused into the sacrum with intrasacral fixation. Neurological findings of these 5 patients were almost similar. They all had radicular pain and sensory disturbance on one side of the foot. 3 of them showed moderate muscle weakness in the ankle area. This slide shows the serial plane X-ray images of the whole spine column of the first patient I previously presented. As already mentioned, scoliosis correction was maintained with moderate thoracic kyphosis alteration. However, when you look at the shape of pelvic brim on each AP image, its oval shape seems to flatten gradually during the postoperative follow-up period. Therefore, I checked the pelvic brim operatorness ratio, PBOR, of the normal population using AP X-ray images. Average PBOR is approximately 50% to 60%, with a higher predisposition in women than in men. It is affected by the magnitude of pelvic incidence. These are the PBOR in 5 patients. PBOR shows a gradual decrease postoperatively, although there were differences in the value of each patient. Discussion. This slide shows the appearance of the pelvis when it is tilted backward. Radiographically, the pelvic brim looks like a round oval in the younger population. However, it becomes a crushed oval when the pelvis becomes retroverted under pathological conditions. Several factors affect the PBOR, such as hip or knee joint contracture, thoracic kyphosis, and SI joint degeneration. Oba presented a loss of PI correction after a long fusion of the lumbosacral fusion. This study has some limitations. It had a limited follow-up period of only 1 year and did not consider PI measurement errors. However, this study showed that PI may change even with a lumbosacral fusion using iliac screws. There are other studies that demonstrate PI increase or decrease postoperatively. Postoperative change of PI magnitude may be influenced by SI joint motion, such as nutation, counter-nutation, or translation. In contrast, several reports have demonstrated that multiple lumbar segments fusion is a potential risk factor for postoperative SI joint degeneration like shown in our patients. However, there are no reports showing neurological deficits on the lower extremities, which occurred 5 to 10 years postoperatively. Regarding the anatomical relationship of the nerve root and the sciatic nerves with the SI joint, we can infer that L5 and S1 roots combined and run caudally and laterally close to the SI joint. This anatomic association can possibly cause direct irritation against the roots via formation of osteophytes of the SI joint. This slide shows the coronal images of case 5, taken at 5, 10, and 12 years postoperatively. Red arrows show the nerve roots close to the SI joint. The SI joint protuberance can be seen, and the root seems to run not straight due to this osteophyte at 10 years postoperatively. So, I hypothesized that based on these findings, lower extremity radicular symptoms at 5 to 10 years postoperatively are caused by mechanical overstress on the L5 and S1 nerve roots due to SI joint degeneration. So in summary, 5 of 32 patients who underwent lumbosacral fusion demonstrated an expected lower lumbar region radicular symptom during the long-term follow-up period. Lumbosacral fusion should be decided with caution because of its higher rate of complications and postoperative sequelae due to SI joint degeneration during the long-term follow-up period. Thank you for your attention.